we'll talk about non-operative and arthroscopic treatment of osteoarthritis. Well, obviously, it's a big problem. You know, we have arthritis leads to 750,000 hospitalizations per year. There's 8 million people with limitations, 36 million ambulatory care visits, and as you can see, the $1 billion in medical costs and more than $81 billion in total costs from osteoarthritis. 350,000 knee replacements per year. The survivorship is 5 to 30 years, cost of $3.5 billion. By 2030, 20% of Americans will be more than 65. That's 70 million people, and 50% of the population greater than 65 will have radiographic changes consistent with DJD. So obviously, this is a big problem. The effect of obesity, child obesity, and lack of exercise are significant problems as well. So obviously, you know, I think it's important. We all get referrals from primary care physicians. Somebody comes in, they're 60 years old, and they're referred in for a meniscectomy because they have an MRI that says they have a torn medial meniscus. They never took an x-ray, so they went right to an expensive MRI when you could just do flexion. You want to make sure you get your flexion weight-bearing x-rays. A lot of times you don't need an MRI in these situations to make the diagnosis. Patellofemoral x-rays as well, sometimes a bone scan, and long-standing alignment x-rays in younger patients. And MRI, obviously, I think is a last resort or a last line in those cases where you think you need it. Obviously, we talked about the cartilage mapping, so we can pick up these cartilage defects a little bit earlier in life and treat them appropriately. So what about the AOS clinical guidelines that JR and his group painstakingly went through all the literature and talked about things that they support, things that they're neutral on, and things they're against? Well, obviously these all make sense. The low-impact exercise, weight loss, education, etc., strengthening, patellar taping, oral visco supplementations in that group, judicious use of intra-articular steroids, and then arthroscopy for meniscectomy and loose body, okay, and then realignment osteotomy. What they're neutral on, these things, unloader brace. How many of you use unloader braces for your patients with osteoarthritis? I use them sometimes. You know, I use them for like weekend warriors, like guys who want to play golf or tennis. They have medial compartment away. They can throw the brace on. They go out and play a round of golf. They play a little doubles tennis, and they're happy with that. I think for them to use it as a panacea is probably not helpful. You will have trouble sometimes getting the insurance company to approve it. So that's an issue. Now, injectable viscosupplementation, although they're neutral, we all tend to use it. You know, when you start dealing with things that have a minimal downside, and whether there's there's a significant placebo effect there, we don't really know. Tibiotubercle osteotomy, probably just based on the literature that we have. And what they're against, obviously, is arthroscopic lavage of osteoarthritis, an interpositional device, and needle lavage. So we really couldn't find anything in the literature to support these things. How many of you in the room use interposition arthroplasties for uterocompartmental arthritis? Anybody? Nope, I don't either, but I know there's some people that do it. Obviously, the nutricidal industry is a huge industry. It's a multi-billion-dollar industry. Oral medications and the things that you find in CVS or Walgreens. And obviously, corticosteroid injections, viscosupplementation injections. I think corticosteroid injections, once they have osteoarthritis, I'll use them liberally for obvious reasons. What about viscosupplementation? What's the role of that? I think that obviously with DJD, you get a decrease in the viscosity of synovial fluid. The hyaluronic molecule within synovial fluid provides joint lubrication and decreased coefficient of friction. There's a number of options. They're animal origin, non-animal origin. They're low or high molecular weight, cross-linked or non-cross-linked. You can do a multiple injection. Now you can do it with a single injection. The question is it safe? Does it work? Are there advantages and drawbacks? Effects of injected HA are described to be anti-inflammatory by reducing the inflammatory cell count in synovial fluid. Pain relief confers analgesia by direct nocioreceptor interactions. And then probably it also works by nitrous oxide, the free radical nitrous oxide. There's a significant increase in concentration with DJD, which causes joint degeneration and synovial inflammation, and the HA inhibits the nitrous oxide. Expanding the HA indications, one study showed isolated anterior knee pain, patellofemoral pain, and I have it found useful in young athletes with patellar chondrosis as an adjunct to other conservative measures. Whether it works purely as a placebo effect, I have no idea, but it could be helpful, especially these young female basketball players with, patellar chondrosis. There's a lot of different preparations. We don't have anything to tell you that's one thing's better than another. The important thing is you don't want to miss the joint, especially if you're given the one-time injection. That's why I don't like the Synvisc one. There's a lot of resistance to it, so you can't really get a good feel of whether you're caught in soft tissue in the synovium or something like that. How long does it last? Well, most studies, which are obviously industry biased, it averages 6 to 12 months, but they can be repeated. Obviously, it's also shown that there's a decreasing efficacy with the increasing grades of osteoarthritis. The best study was probably one that was prospective, multi-center, double-blind, that they received HA or saline with a 27-week follow-up and showed to be better in the group with HA. There can be adverse effects, a pseudoseptic response, particularly seen with Synvisc, rash and bruising, etc. So occasionally that can be a problem. What about arthroscopy? The question is, the classic controversial study obviously was a Moseley study, shown was a prospective, randomized, double-blinded, sham-controlled. The efficacy of arthroscopic debridement in treating painful knees with underlying arthrosis showed to be of no clinical value, and it led to Medicare denial of arthroscopy for these patients. The criticisms was that it was used a non-validated outcome measure. They included patients with significant malalignment or advanced disease, and that there was a focus primarily on an older VA population. Recently, I saw JR write a nice editorial in the recent Arthroscopy Journal on expanding on the indications for use of osteoarthritis, and that was followed by a letter to the editor talking about selection biases study, and this was written by a Dr. Elahi, who was in charge of the arthroscopy service where Moseley worked during the 3-year enrollment process. And he claims that the patients were seen in their knee clinic first, and that those that they thought appropriate for arthroscopy were offered such. And that those that they thought arthroscopy was no benefit, some of them found their way into Dr. Moseley's study, so that there was a big selection bias of the patients who ended up in that study in the first place. And then the Kirkley study also eliminated those patients who were most likely to benefit from arthroscopy, the patients with significant meniscal tears. And what Elahi stated that arthroscopic debridement does not give lasting relief from symptoms of knee arthritis, but can effectively address specific pain generators such as large meniscal tears, loose bodies, and unstable articular cartilage flaps in knees with or without underlying arthrosis, which makes a lot of sense. So I think the bottom line is you use common sense, address pain generators if they felt to be a significant time-buying procedure. I think the younger, the more active the patient, the more you can push the envelope. So if you have a 38-year-old with some medial joint space narrowing and degenerative tear of the meniscus, and they don't have true mechanical symptoms, you think maybe some of their symptoms are coming from the meniscus, you may be more prone to scope them rather than the 70-year-old with that same disease. So I thank you very much for your attention.